Hello, and welcome. Today we're diving deep into a serious heart condition known as infective endocarditis, focusing particularly on its impact on heart valves. This is a journey into the heart of the matter, exploring its causes, how it damages the body, and what we can do about it. So, what sparks this infection? Infective endocarditis is primarily caused by bacteria entering the bloodstream and settling on damaged or abnormal heart valves. These bacteria, often originating from sources like dental procedures, intravenous drug use, or even skin infections, find a foothold on the valve surface. Common culprits include Staphylococcus, Streptococcus, and Enterococcus, but other microbes can also be involved. Pre-existing heart conditions, such as congenital heart defects or prosthetic valves, significantly increase the risk. Now, let's understand what happens when these microbes invade. Once attached to the valve, the bacteria multiply and form colonies, creating what are called vegetations. These vegetations are like tangled masses of bacteria, platelets, and other cellular debris. They disrupt the normal function of the valve, leading to leakage or obstruction of blood flow. Moreover, these vegetations can break off, turning into emboli. These emboli can travel through the bloodstream and lodge in other organs, causing stroke, kidney damage, or other serious complications. The body's immune response, while trying to fight the infection, can also contribute to further valve damage and inflammation. Infective endocarditis is not a common disease, but it's certainly not rare either. Its incidence varies depending on factors like geographic location, healthcare practices, and the prevalence of risk factors. Individuals with pre-existing heart conditions, those who inject drugs, and patients with prosthetic valves are at a significantly higher risk. The elderly are also more susceptible due to age, related valve changes, and increased exposure to medical procedures. The symptoms of infective endocarditis can be diverse and often develop gradually over days or weeks. Common signs include fever, chills, fatigue, and night sweats. Heart murmurs indicating abnormal blood flow are often present and are a key diagnostic clue. Other symptoms may include shortness of breath, joint pain, skin lesions like petechia or splinter hemorrhages under the nails, and even neurological symptoms if emboli reach the brain. It's crucial to remember that the symptoms can be subtle, and early recognition is essential. Diagnosing infective endocarditis involves a combination of clinical evaluation, blood tests, and imaging studies. Blood cultures are crucial to identify the causative bacteria and guide antibiotic therapy. An echocardiogram, either transthoracic or transesophageal, provides detailed images of the heart valves, allowing doctors to visualize vegetations and assess valve function. Other tests like chest X-rays and electrocardiograms, ECG, may be performed to evaluate the impact on the lungs and heart's electrical activity. The modified Duke criteria are often used to standardize the diagnostic process and increase the accuracy of diagnosis. While the term infective endocarditis broadly covers the disease, it can be further classified based on factors such as the causative organism, the valve involved a native or prosthetic, and the duration of the infection, acute or subacute. For example, endocarditis caused by highly virulent bacteria like Staphylococcus aureus tends to progress rapidly, while infections caused by less aggressive organisms may have a more gradual onset. The location of the infection, whether on a native valve or a prosthetic valve, also influences treatment strategies and outcomes. The cornerstone of treatment for infective endocarditis is prolonged intravenous antibiotic therapy. The specific antibiotics used depend on the type of bacteria identified in the blood cultures and their antibiotic sensitivities. Treatment typically lasts for several weeks, and patients often require hospitalization for monitoring and administration of medication. In some cases, surgery may be necessary to repair or replace a damaged valve, particularly if antibiotic therapy fails to control the infection or if complications such as severe heart failure or embolic events develop. Surgical intervention aims to remove infected tissue, repair valve damage, and prevent further complications. Prevention is key to reducing the incidence of infective endocarditis. For individuals at high risk, such as those with prosthetic valves or a history of endocarditis, antibiotic prophylaxis is recommended before certain dental or medical procedures that may introduce bacteria into the bloodstream. Maintaining good oral hygiene is also crucial, as is avoiding intravenous drug use. Prompt treatment of skin infections and early recognition of potential symptoms are also important preventative measures. Regular check-ups with a cardiologist can help identify and manage underlying heart conditions that increase the risk. The prognosis of infective endocarditis depends on various factors, including the causative organism, the severity of valve damage, and the presence of complications. Early diagnosis and prompt treatment with appropriate antibiotics significantly improve outcomes. However, even with optimal care, infective endocarditis can be a life-threatening condition. Recent research is focused on developing new diagnostic tools, improving antibiotic therapies, and exploring novel surgical techniques for valve repair and replacement. Studies are also investigating the role of the immune system in the pathogenesis of endocarditis, with the aim of developing targeted therapies to modulate the immune response and reduce valve damage. These advances offer hope for improved outcomes and a better understanding of this complex disease.